So what is trauma and when is it enough to send you to the ER? You'll know in just a few minutes. We've got a doctor in the house. The Health Source Podcast starts right now.
You are listening to the Health Source Podcast, presented by the Marshall Health Network. Now here's your host, Rick
Welcome
Lord.
to the Health Source Podcast on the campus of Marshall University. You are watching the Health Source Podcast presented by the Marshall Health Network. I'm your host, Rick Lord, and today we are pleased to bring in Dr. Errington Thompson, the head of trauma for the Marshall Health Network. Doctor, thank you for joining us today.
Happy to do it.
So you hear the word trauma a lot.
Yes.
And a lot of people might have some misconceptions. So just give us the Cliff's Notes version of what trauma is and what maybe it isn't.
Trauma is when your day goes bad all of a sudden.
Great way to put it.
You know, trauma is the car crashes. It's the falls off the roofs. It's the motorcycle crashes. It's the sudden injuries that can lead to hospitalization. Those are the things that I deal with on a daily basis.
By the way, Dr. Errington Thompson sounds like a primetime show. We got to get a hold of some of the networks around here.
I need to be, instead of the pit, it should be Dr. Errington Thompson. There you go.
Errington Thompson, MD, starring Errington Thompson. Yeah. So walk us through a typical day. I know that trauma surgeons and doctors and people in the ER work excruciatingly long hours and unusual hours. What is a typical day for someone in the trauma unit?
So trauma, because it is random, you could have a day like I had on Sunday where we did not have any major trauma at all.
That's a good day.
Everybody was nice. Everybody was nice to each other. Everybody drove well. Or you can have a day like my partner had on Friday night where it seems like everybody was driving into trees or off of roads and falling off of their motorcycles. It was a really, really bad night where we admitted somewhere around 10 trauma patients, with 4 or 5 of them being very, very sick.
You know, I brought up the TV thing in jest, but I think a lot of people get their knowledge of trauma through watching that. And sometimes there are some, what you see in Hollywood isn't exactly what real life is like. What is a typical situation? Walk us through that scenario where a patient comes in. How does the team get involved, and walk us through from A to Z how that happens?
The good news is in West Virginia, we actually have a trauma system, which means the state designates trauma centers. And because of that, there are certain criteria that we need to meet. There's also pre-hospital criteria. So, for example, if somebody gets into a major car crash, Cabell County EMS is dispatched. They will assess the scene, and depending upon the patient's vital signs, how fast the patient's breathing, what kind of interventions they do, they will call into the emergency room, either at St. Mary's or Cabell. And then, depending upon what they're telling us, we can then alert the trauma team as a priority 1 or priority 2 trauma, which means priority 1, of course, is the sickest patients. Yeah. Me as an attending need to be at the bedside within 15 minutes. And so that calls in a lot of people, respiratory, the emergency room physician, all the lab folks, x-ray. You would be surprised. It's a whole host of people that come to take care of that patient.
And what amazes me about the job that you do, the challenges of making literal life-saving decisions on the fly under pressure with limited information. I mean, that's got to be tough.
Again, the good news is it's not like, you wake up one morning and all of a sudden you're a trauma surgeon, right? And so all of a sudden now you have all of these decisions to make. But instead, it is a process, right? We went to medical school. We went to residency. We did our fellowship. So throughout that whole time, you're learning how to make those decisions. So when I come to the bedside and somebody's blood pressure is low, they were in a car crash, I already have an algorithm that has been well worked out. I didn't make it up. That has been well worked out that we can use to take care of that patient. And so although there are life-saving decisions that we need to make, for the most part, these have been tested through research and data.
And talking about pressure, I mean, not only all of that you just mentioned, but also balancing speed, because time is of the essence in many of these cases, with precision.
Yes, you need to make, so that's one of the reasons why some doctors really can't be trauma surgeons. I mean, they may like to, but they can't. It's because some doctors are a lot more methodical in how they do things. They want to sit down and think through this. And you need to make decisions sometimes very, very quickly at the bedside. And you don't have 15 or 20 minutes to
Right.
ruminate over it.
So first 60 seconds, someone comes to you, you're at that bedside. What goes through your mind in the first minute?
Are they sick? That's the first thing that goes in through my mind. Are they sick? Do we need to do something very, very quickly? What are their vital signs? One of the simplest things is, what do they look like? Yeah. Just looking at them from the bedside, what do they look like? Do they look like they are sitting up in bed and they're on their phone texting? Or do they look pale as a sheet and can barely get out a word because they are so short of breath? That's what you need to be able to assess in the first minute.
And that's where experience comes into play, because you've done it for so long that you have this wealth of knowledge and this vault of seeing these different types of situations that you can lean on to make those accurate assessments quickly.
That's correct. And again, I'd like to say that I do it all by myself and nobody ever helps me, but no, instead it's a team effort. And so I've got residents, I've got nurses, I've got emergency room physicians, all of them helping to put with input so that I can make a rational and thoughtful decision for that patient.
And I'm sure sometimes you got to have a short memory, because on to the next one, and you can't let things linger. Do any moments stay with you?
Of course, there are always some patients, for good or for bad, that stay with you, and of course you learn more from the bad ones. Several months ago, we had a really, really terrible ATV crash with some kids, and both kids came in coding, which just never happens. Where, first of all, it's rare for a child to
Just
to
explain
code.
that for our audience who might not know the term.
It basically, they came in with no vital signs. Both children had been placed on breathing tubes. Both children had EMS pumping on their chest when they came in, and that was one of the toughest ones. Yes,
Yeah.
yes.
So how do you cope? Do you have a coping mechanism that helps you deal with bad outcomes? Because not everything's going to have a rosy outcome.
So one of the things that trauma has developed over the last probably 10 years or so is these decompressive episodes. And so there are nurses that have been trained in counseling. And after one of these traumas, they will talk with nurses. They will talk with everybody who's in the room who wants to be a part of the discussion to help them decompress. And we have them also for some of the floor patients.
Now, before we do these shows, we send out just kind of like a brief, like, here's what we're going to talk about, just to get kind of a general blueprint. We don't go over specific questions, but just in general. One of the things that I found interesting in one of your replies is that you don't like to call them accidents. Explain that a little bit.
So this is a push that the trauma community has been working on unsuccessfully for 20, 25 years. When you hear the word accident, it's almost like there's nothing we can do to prevent it.
Right.
It's almost like God ordained it. And so I don't like to use the phrase motor vehicle accident. Instead, it's a motor vehicle crash, because there's lots of things that we can do to prevent crashes, right? We can stay off of our phones. We can not be high when we drive. We cannot drive too fast, especially on these windy West Virginia roads. So those are just a couple of the things that we can do to prevent crashes. So I'd like to not use accidents and use crash instead.
And that is a big problem, especially with the technology, is distracted driving.
Yes.
You see it all the time, people on their phones, and they're texting and not paying attention, and they think, oh, I'm just looking down for a second, but sometimes that's all it takes. So other than motor vehicle incidents or motor vehicle happenings, what are some of the other preventable accidents or preventable things? See, now I'm catching
You can't help
myself.
it. You can't help
What are
it.
some
You can't help
of
it. I
the
know.
more preventable injuries that you see consistently?
So now we're recording this in the middle of winter.
Right.
And winter brings cold weather, it brings icy rain, it brings snow, and so you have to worry about falls. We have a large elderly population here in West Virginia, and so falling once you pass the age of, say, 40 is probably not a good idea.
Right.
Right before Christmas, you were worried about people up on ladders and falling. And so, again, it's about thinking about, is this a good idea, putting this ladder up against the house? Am I on concrete or am I on dirt? And is this the angle of my that I have to put the ladder on? As far as ice, do I need to get the mail today? right? Is there anything in that mail? Can I wait until the ice thaws? Did I put down ice melt before all of this covered my walkway? Those are the kind of things I think you need to think about in order to prevent falls and in order to prevent trauma.
And it's amazing that people, especially if you grew up out here, you should know what ice is and what it can do. But there are people that think that it's just like a normal walk. But with that layer of ice on the sidewalk, it's anything but.
And you have to remember also that people get into a routine.
Yeah.
People get into a routine. They check the mail every day at 2 o'clock because the mailman comes at 1:45 and has done so for the last 20 years. I'm going to go check the mail. No. Think about it for a second. Just think about it for a second. And that's the difference. We take care of probably about 15 to 20 people who basically die from falls every year. Not necessarily falls on ice, but falls themselves. There's over 1 million people who get hospitalized in the United States because of falls. We think about falls as no big deal. And when you're my grandson who's 23 and he's all bowed up, he could fall 100 times and nothing's going to happen to him. On the other hand, if you're 65 and you're on blood thinners, falling, that's a problem.
And things break.
Yes, yes.
A lot more fragile when you're old heads like you and I.
Yes, exactly. That's exactly right.
Speaking of which, you've been in this game for a while. What are some advancements that you've seen more recently in the last 10, 15 years that have you excited about with trauma care and what we've been able to diagnose easier or treat better?
So there's actually a lot that have gone on in the last 15 or 20 years. First of all, our antibiotics are a ton better. We have a wide range of antibiotics to treat a wide range of bacteria that seem to continue to pop up their ugly head. We have a range of medications to relieve pain that we really didn't have when I was an intern. And I know fentanyl's a bad word, but we can actually use fentanyl very, very safely in the hospital, and it's a wonderful drug for relieving pain. So that's another thing that I've seen. There's been advances in the operating room to help stop bleeding a lot quicker. We have actually medications that we can give patients to reverse bleeding in the operating room, which is very, very remarkable. I mean, you can
reverse bleeding.
I can be operating on somebody in the operating room and see just what we call a general ooze, where they shouldn't be bleeding, but yet you see bleeding everywhere. Right. We can give this medication. Within 5 minutes, that whole thing dries up. Wow. And I wish I could tell you it's my wonderful skill as a surgeon, but it's the medication. So we've made a lot of progress with medications, and then just our processes of getting patients to the hospital, getting our patients evaluated quickly, getting our patients up to the operating room quickly. That makes a huge, huge difference in outcomes.
We talked earlier about the long hours, the unusual hours. Sometimes days are hectic, sometimes they're not. How does that affect your family life? I'm not trying to dig in your personal life.
What family life?
Exactly. I was going to say, because that's just something that
Dr. Denning would want me to say. In what family life? No. So this is another thing that has changed over the years. Is that when I was a young trauma surgeon, you were expected to be in the hospital basically every day out of the week. And now we do shifts where I will do the ICU for a week. I'll take 1 or 2 days of trauma call. And then there's a week where I'm not on the ICU, where I'm only taking call like once or twice so I can have some time to decompress, have some time to sit around with my wife and play gin rummy or whatever it is.
Does she beat you or do you beat her?
I never win.
Happy wife, happy life, right?
I wish I could tell you I wasn't trying, but it's like I'm playing checkers and she's playing chess. Yeah.
Well, we talked about the difference between accidents and preventable injuries. What advice do you have for people that maybe find themselves in a situation where they might need to go to the ER, and what can they do on scene before help arrives?
It kind of depends upon what is actually going on at the time. One of the things that was a big push about 10 or 15 years ago was tourniquets, where we are trying to, it's called Stop the Bleed, which is a national program that's run out of the American College of Surgeons, which we went out to schools and to colleges and to workplaces and taught people how to place tourniquets. And the thought process is, if there is extremity bleeding that you think is arterial, then putting on a tourniquet could be life-saving. So that's one of the things that you can do. The other thing is, if you think you need to go to the emergency room, go to the emergency room. That's usually, I mean, you don't want to make the wrong decision, go home, and then wake up on the floor. Right. And so that's the thought.
So is that the basic thought, is to err on the side of caution? If it's a situation where you're not quite sure, is this something I can just handle with a trip to urgent care? Or is this something where I might want to go to the ER? And a lot of people, unfortunately, make those decisions based on their own health care, what they can afford, what their insurance is like.
That's a big thing. That's a big thing. And that's one of the things that I, as a surgeon, I don't want to get political, but universal health care would be so helpful in a way. So therefore, we can remove that kind of thing. Yeah. I can tell you there's a patient that I took care of many, many years ago. Very, very knowledgeable guy. He fell off his motorcycle. He had a bunch of rib fractures. He had no insurance. And so I'm in the emergency room discussing with him placing a chest tube, which is a tube that goes between your ribs into your chest in order to re-expand your lung.
So he can breathe.
So he could breathe. And he wanted to know how much that costs. And I was honest with him. I have no idea how much it costs. All I can tell you is that you need it, right? And then he wanted to say, well, if I don't get the chest tube, what are the chances of me making it? What kind of complications would I get? And that's a very difficult conversation that you'd like to avoid.
Yeah, that's tough, but it's something that we see far too often, is people making decisions based on their financials rather than their health. And health should be, one of those things that transcends what you can or can't afford. But I don't know what, like you said, we could go hours to try to deep dive into political solutions for that problem. So give us the 30,000 in the air foot version of your career. What you're most proud of in what you've been able to do over the course basically of your entire career.
Well, I think the one thing that I'm most proud of is actually being the director of trauma here at Marshall. We've had some really, really wonderful residents who've come through, and when I go to these conferences and I can see them out, they've now been out on their own for several years. They're successful. That to me makes me the most proud that I had a hand in their development and their education. I have published several papers over the years, and there's a few of them that I really, really like. I published one several years ago that was actually on lawnmower rollovers, which you go...
It's very specific.
It was. But the thing is that we actually have probably 10 to 15 patients a year, because we have sides of hills like this,
very hilly,
where unfortunately they do roll over their lawnmower, and unfortunately there are 80-year-olds who are on those lawnmowers who've been doing the side of the hill for 50 years, and now that something went wrong, right?
Yeah.
So what we found in that paper was the older you are, the worse your outcomes, and probably by the time you are 80, you probably should find your grandson to do that side of the hill for you.
Yeah, that's great advice. So we'll get you out of here on this. Over the next 5 years, 10 years, do you see any emerging technology that you're excited about in this field and where we're headed?
Again, I think that we will see advancements in the operating room. I think that trauma is going to embrace a lot of the robotic advancements that we've seen. I think that whole thing is going to become a little bit quicker so that we can use it in trauma. I think that we'll see a lot of minimally invasive trauma advances. And I think there's going to be advances in drug therapy that we're giving patients. One of the things that we really, really need to work on is pain control in our trauma patients. We see, I would like to say thousands, but it's not thousands. We see hundreds of patients who have rib fractures. And rib fractures are just terrible because they hurt every time you take a breath. And you'd like to not take a breath until they heal. Unfortunately, that's going to take weeks. Yeah. So if we can get better pain control in those patients, and we're working on it, there are a lot of things that we're doing now, but I'd like to see that improve.
That's awesome. And maybe in 5 years, we'll have Dr. Errington Thompson on ABC or CBS or NBC, one of those networks. I would watch it.
Well, thank you. That'd be nice. That'd be nice.
Well, pleasure having you today, sir, and thank you for keeping everyone safe out there. And we hope you continued success in the future with what you're doing out there, and your valuable service in trauma services.
Thank you. I enjoyed this interview.
Dr. Errington Thompson joining us today, and be sure to like and subscribe so that we can keep episodes like this coming. For the doctor, I'm Rick Lord. Until next time on the Marshall Health Source Podcast, take care.
That was the Health Source Podcast, presented by the Marshall Health Network.